Now, what do patients say? Well, fairly hefty surveys have been done of what patients with terminal diseases want, what they say about it. And these have been done using qualitative methods, so it's not just ticking a box, questionnaire type stuff. It's in-depth interviews with analysis of the themes that come out of the interviews. And the most important thing for most people is adequate symptom control. So whatever the symptom is, people would like it controlled as so far as you can and as well as you can. The majority of people want to avoid prolonged dying, a month in intensive care with a tube in every orifice. And people find having a sense of control over the end of their life one of the most important things. And that's one of the things that motivates the people who badger for physician-assisted suicide. They want to have ultimate control over how their life ends. And our society denies them that. And of course, they also would like to relieve burdens on their loved ones. They like to strengthen the relationships that are existing through an acknowledgement of imminent death. And this is one of the hard ones to get across to those people who don't tell mother that she's dying, brigade. It actually strengthens relationships and it opens up communication and brings people closer together if it's acknowledged and talked about. And there's lots and lots and lots of good, hard evidence to show this. Now, if you don't make end-of-life plans, I've already alluded to bad things happening, there are also cultural differences. This survey was done a few years ago. I realize it's not about PSP, but I hope it's relevant to our talk today. In some countries, people get stuff that they don't really want. And this appears to happen in Japan, where doctors and families don't talk to patients about what's going on, and patients can end up with invasive ventilation in motor neuron disease, whether they wanted it or not. Now, that doesn't happen here. It doesn't happen in most of the European Union. It doesn't happen in the United States. And things seem to be changing in Japan as well. Now, just as an aside, Fiona mentioned neuropalliative rehabilitation. I'd like to draw this to your attention. What is implied by this, up here, no, there it is. What is implied by this is the pathway that people take from the beginning of their illness to the end of their illness. So death is certain for all of us and at all times. You may have an acute illness. You may go to see the neurologist and you get a diagnosis, and in a rapidly progressive condition, you go very, very quickly to terminal care and death. So massive intracerebral hemorrhage, very, very quickly. But with other conditions, it may go, no, I want to go this way. With other conditions, it may go much more slowly. So someone who has a spinocerebellar degeneration or one of the limb girdle dystrophies or whatever, their path, no, the arrow keeps disappearing, their path will be a very, very, very long one, 30 years plus. I once saw a chap in his 90s with limb girdle dystrophy who was still living alone. He'd outlived 2 previous neurologists to me in Leeds. Admittedly, one of them had killed himself, but... So, people with motor neuron disease are on the fast track. People with PSP are on the slower track. There's diagnosis, there's what kinds of treatments they might be offered, there's rehabilitation, there's palliative care. And trying to combine both rehabilitation and palliative care at the same time seems to be very difficult for rehabilitation doctors to get the palliative care idea. And it seems to be quite difficult for palliative care doctors to remember and get the idea about rehabilitation techniques. But for the kinds of patients we're talking about and thinking about today, you need both all the way through their illness. And so the concept of rehab and palliative care and neurology working closer together is a very excellent one. And I'm proud to say that I have landed in a team at Bethlehem Hospital where they've been doing this with great success without even knowing what it was called for the last 10 years plus. Now, who should do this talking about advanced care planning? Well, I have a very strong and firm belief that the person who makes the diagnosis should do it. But I know perfectly well that many of my colleagues are unwilling or incapable of doing it. So the rest of us will get involved. You guys will get involved. I bet there's not a person in this room who hasn't been asked in some way or other, very directly or very roundabout, about end of life with patients like the ones we're talking about. So you'll get asked too. We're all going to get involved. The whole multidisciplinary team need to be aware of this. They need to get involved in it. We can't just leave it to the palliative care team. They're good at it. They're trained in it. We need to go to them for expert help, advice, and support. But they can't do it all because they've got all those cancer people to look after and all the people with chronic lung disease and all the people with chronic heart disease who are not going to see them. Much more common conditions than any of our difficult neurological diseases. So we can't leave it all to them. We've all got to do it.